Hello and welcome to the third episode of the Novan-sponsored Molluscum Miniseries, Advances in Understanding and Managing Molluscum in Children. By now, I hope you've watched episodes 1 and 2 to learn about molluscum and molluscum therapies. Now in episode 3, Dr. Nanette Silverberg and Dr. Adelaide Hebert join me, Jen Dawson, for a question and answer session. Thank you both so much. These talks were extremely informative, and I appreciate you both very much. First question, with the association of molluscum being transmitted horizontally as an STI, should providers be concerned about potential child abuse when it is present in the groin region in those who are very young? Dr. Silverberg, I'll go to you first.
I think that the interesting thing about molluscum is if you really look at most kids, you'll see a trail of where it came from. If you ask, it's usually a sibling. There's a setting where it was acquired, daycare, a child care. So there's often a trail. We don't generally think about it that way because we often see molluscum in other parts of the body as well. So it often is not the case. It's more likely not the case. It's unlike warts in that respect. Warts, we have to think about it a little more aggressively, but particularly in smaller kids, there often is a reason for transmission: a sibling, a cousin, a pool party, something that went on. And if you really look, you can often tease that out. And I think it helps us. It helps us to know that the transmission modalities, because it helps us identify a source. If you're treating 5 kids in a family, but yeah, I mean, it has to be in your mindset always when you see extensive lesions in the groin area. If I saw lesions around the anal area, I don't think we see lesions around the anal area normally. We don't see that, perivaginal lesions in small kids. We see them on the buttocks. We see them on the inner thighs. We see them on skin surfaces, but we don't really expect to see them on vaginal, mucosal, or perianal skin. So in those 2 locations, if I would see them there, I'd have to give pause to that and do investigation. But I don't. How do you feel about that, Vita?
Yeah, I think as pediderms, we're pretty sensitive to child abuse. I mean, I look at the parent's reaction. I look at the child's reaction. I mean, I think it's almost it's an observational, but it's also a gut feeling. Are they really uncomfortable talking that? Do the parents get instantly defensive? I think we have to judge any child where we suspect child abuse, whether it's this or trauma. We really have to just be thoughtful. But I agree with what Dr. Silverberg said. We don't see it quite that often in the very youngest children in regions that would make us be a little bit more suspect of child abuse.
Thank you. Next question. What do you recommend in terms of when to wash off cantharidin? I have heard so many different strategies and recommendations. Dr. Hebert, we'll go to you first.
Well, if I have a very fair-skinned child, I generally will limit it to 1 hour. If I get to Fitzpatrick 3, 4, and 5, I can generally go 2 hours. Now, I think it depends on what your compounded cantharidin contains. So I'm speaking to the compounded agent that I use in my clinic. You may have a different experience. But certainly if I get feedback that the child got big blisters, we might cut back the time. But I generally say 2 hours is my recommended max. Occasionally the parents forget and the blisters get big and I hear about it. But we do try to remind them to wash it off in 2 hours. And I generally look at my watch and tell them what the time is.
Oh, that's so true. That's exactly what I look at the time also. So, I think that you're correct. It really totally depends on the formulation you use. Some of them are a little, and also if you just got a new bottle, probably not as intense as some of these old bottles where they dry out. It's probably a little more concentrated. I do also do the same. I say 2 hours in the smallest kids, and I say like 4. We can go in the original study that I did as a fellow where we called 300 parents, it was like 4 hours, wash off in 4 hours. But the guidance that I've always given is a handout. And I think it's okay. It's important to give some guidance. And it says to check every half hour for blistering, and then wash at the first sign of blistering. But I agree with you. The smallest kids, and those like really light skinned little blonde kids with like transparent skin, I do also shorter contact times. I don't think you go wrong either way. I think what it really turns out is that you're really giving good skincare and you're moisturizing the area, so you're soothing the kids. I think it's not necessarily, it doesn't limit the efficacy if you do it a little bit sooner. You can always retreat. There's no downside to that.
Excellent, thank you. Does the number of lesions or other factors like stage in the progression affect preference of treatment?
Oh, so first of all, I don't love to treat kids who've got inflammatory lesions on day one. I was trained as a fellow. Okay, that was my Tony Mancini, Big Powler said to me, we treat inflammation first. We don't blister atopic dermatitis or dermatitis because it carries staph on it. So I go through the same. I don't treat lesions that have they don't blister areas that have a lot of dermatitis. I tend to recommend moisturizing, avoiding rough sponges that spread it. I give the topical steroid medication for the dermatitis and good skincare. If they come in and they have a couple of lesions and they're not inflamed, I'm more than happy to treat on day one. But I often do defer and I get the skin under control. But some of those inflammatory lesions are if they have the boat sign. I think you can look at that Berger study and it talks about how, giving topical steroids cleared a third of those lesions. But it's worthwhile to just clear that group of lesions first, clear out the background inflammation and then treat. But I believe that the VP 102 trials didn't necessarily remove dermatitis, but I do that in my practice.
Dr. Fair, any comments?
Yeah, I would say when they're in my clinic, I just go ahead and treat them. I might stay away from the really inflamed lesions. And again, if I can avoid treating the face, I might leave the face alone and treat other areas. Again, not going where the creases are, particularly in the arms and legs, because it can be uncomfortable. But I think the parents come to see me, they want treatment, and we might put a treat on, and I treat no more than 10 lesions at any time on any child. And again, avoiding the face if I can. And sometimes I do have to treat secondary infection, but I'll just treat that and the atopic dermatitis I just lay out the plan, but generally I treat on the day they show up.
All right. Okay. And I guess I'll mention, for those really extensive lesions and atopics, like I have kids who come in, I count them with the kids. When you hit 50, I start to think about cimetidine early. If the combined number of lesions exceeds the child's fingers and toes and my fingers and toes, we're in trouble.
I like that as a measurement. Just a few more questions here. Angel Pagan says, thank you so much, Dr. Silverberg and Hebert. This question is for Dr. Hebert. Are you aware of any studies, or do you think the Berdazimer gel may have applications, uses, or benefits for inflammatory skin diseases that don't share the viral etiology that eczema, psoriasis, etc. do?
Well, definitely I'm talking off label here. I mean, I think that Berdazimer has many potential uses. And I know Novan, the company that's working in, is probably going to broaden some of the reach that they have within dermatology. But I think they want to get this first drug on the market, and then they'll probably begin some research that will delve into many of the arenas where we have unmet needs. Particularly, I've certainly shared with them some of my thoughts, and I hope the listeners tonight, if they have ideas, they would reach out to Novan and share them as well. They may not work on that in the immediate weeks, but perhaps in the years to come, we will have the opportunity to develop those opportunities.
Dr. Silverberg, any comments?
No, I totally agree with that. But I think that Vita has, when you look at your talk, one of the things that always that really strikes me is that there's just this tremendous unmet need in molluscum, and we spent a lot of time, trying to get where we could, and so I think I'm very happy that there are, the science now behind molluscum and the science in your talk about the mechanisms of action and where these this agent falls in, it's very it's just really exciting to know that molluscum has come is now like it's a real it's come of age. It's a real scientific issue.
Yeah, it's really got some gas behind it now. And the two of you did a beautiful job of highlighting the unmet need and just how devastating this really is. A couple more questions regarding cantharidin. Should the location or thickness of the epidermis be considered for the time of the cantharidin application?
Well, I think certainly if I've got it on the face, I might leave it on a little shorter. If you're in the creases or any skin folds or thinner skin, and again, I mentioned the very fair skinned child, yes, that could impact both the amount that I apply and the duration that I allow the product to stay on the skin.
And sorry, go ahead, Dr. Silverberg.
Perfect.
As a follow-up to that, is 7% something that could go up to 4 hours?
I didn't do that clinical trial, so I can't remember off the top of my head how long they left it on. But again, they did get some blistering. But again, overall, very well tolerated. Side effects that you would expect from a cantharidin product were discerned during the clinical trial. But I think as pediatric dermatologists, all of us have had cantharidin use in our training, and we would know how to manage those potential side effects.
Fantastic. Okay, the questions keep rolling in. Thank you so much for staying on. We'll try and wrap this up here. Any advice for patients having severe inflammatory reactions to their molluscum, such as patients post-chemotherapy or bone marrow transplant? That's a good question.
I guess, I think that ultimately we don't want to do harm. I think that's always like a child's general health is so vitally important. I don't want to give, I can't remember the last time I needed to give oral steroids for a severe molluscum id reaction or even the EM reaction. I mean, most of that is really just a good topical steroid. And I think we're so adept in dermatology, in pediatric dermatology, at good topical care and avoiding systemic agents, and not interfering with the general health of the child if we can. I do think, in those cases, sometimes we do end up, requesting really talking to the hematologist. Can we do you feel comfortable with my giving antihistamines, looking into interactions, but, good atopic care really goes a long way in those conditions. I don't really see negative experience. I usually see positive experience when they reconstitute, that they start to get clearance, not necessarily. I don't feel like id reactions are necessarily a bad thing, even if they look great. I don't know. How do you feel about that, Beta? Do you have a lot of experience with the cancer patients?
Well, I think when you have a patient who's really immunocompromised, sometimes they have bigger battles to fight than molluscum, although I usually treat molluscum. If they're in the throes of immunosuppression, I might not worry about the molluscum right then. Just as Dr. Silverberg alluded, as their immune system comes back, they reconstitute, often the molluscum will be managed more effectively. But if the parent really wants something, and remember, these parents have so little control, they're looking for something that they can treat. That might be a time I would curette one or two of them or a few more, put the numbing cream on, leave it on for a good while, use some ice while I curette them. That way you're not interfering with the chemotherapy protocol. You're not leaving an open wound, which could delay radiation therapy. The parent feels that you did something. And I think that might be a moment where I know I wouldn't interfere with anything else going on, as long as I can create that small scraped area and not be in a field where they would get radiation, because that would have to heal first. That might be the approach I would take, or I might treat just a few molluscum, again, to not cause any problems, not cause harm, and just try to get that patient on the road to recovery.
Yeah, that's actually, it's a great point. It's one of those situations where I don't use immunotherapies a lot in people who are undergoing a lot of other treatments. I feel like I don't want to mess with their immune system when I know the hematologist, oncologist has to get it just right.
Yeah, that's a great point. Okay, our final question, and I'm going to mispronounce this word, so hopefully the two of you can help me. Any experience with synechithesgens or virigen? Saying that right?
Oh, I had one patient. Somebody gave 50 axillary and flank lesions. He went down the inner arm like this, and the kid got a brisk response. He was bright red and swollen.
Oh no.
It's not good. I said so. That was when it had first come out, and it was sampled first to adult dermatologists and not to me. And then I didn't really request samples after that. I don't know what's your experience, Beta.
Well, first, I don't think it's FDA approved in children, so that's
Right.
the challenge, and then it has to be kept in the refrigerator. I don't really have any personal experience in children. I have used it in a couple of adults who had warts, and the real indication for that is warts. And I have had warts that they just wouldn't go away, and I tried everything, and only when I used that particular product did I actually result in the involution of the wart. So I think it has a role to play, but maybe not in the molluscum arena.
Right. Yeah, absolutely.
Excellent. Well, I want to thank you both for being here. I want to especially thank Novan for bringing you to Pedra with this information. As I said it before, you two beautifully highlighted the unmet need and all of the amazing work that's now being done in this particular area. So thank you for that. And thank you all to our attendees for joining us this evening. We will make a recording available so that you can go back and revisit these talks. And I hope everybody has a wonderful evening. Thank you. Thank you so much for watching. Again, I would like to thank Novan for sponsoring this series. If you would like additional information about molluscum or want to see more resources, please visit our website at www.pedraresearch.org. If you have questions, you're welcome to email us at info@pedraresearch.org. Thanks very much.